meetings. So I'm going to be doing small case vignettes, and you can think about the answer.
Poornima Ramanan. I'm a transplant infectious diseases provider. I work at the University of Colorado in Denver, United States. Today I'm going to be talking about fungal infections in immunocompromised patients. Because my clinical practice mainly involves taking care of solid organ transplant and hematopoietic stem cell transplant patients, I'm going to be focusing on fungal infections in transplant patients. I will not be covering other immunocompromised patients, such as those with HIV or AIDS infection. So we are going to, do short cases or clinical vignettes. I had originally intended for this talk to be an interactive session, but we live in strange times and, with online meetings. So I'm going to be doing small case vignettes, and you can think about the answers, and then we'll discuss the specific pathogen. I have no conflicts of interest to declare. And learning objectives, again, we're going to be talking about opportunistic systemic mycosis. And I've divided the talks based on pathogens. We will classify them into three broad groups. The first group will contain yeast, and in that, I'll cover a few pathogens, and then we'll move on to dimorphic fungi, and then we'll move on to mold or filamentous fungi. And again, in that group, we have the hyelohyphomycosis, and then we have pheohyphomycosis, which are infections caused by dark walled filamentous fungi. Okay, so I just want to start with the study. This study that was done by the Transplant Infection Surveillance Network in the United States looked at about 16,000 solid organ transplant recipients, and they found that about 3% of them had developed invasive fungal infection. Among these infections, Candida caused anywhere from 50 to 85% of all invasive fungal infections, and therefore are the most common type of invasive fungal infections in transplant patients. The only exception is lung transplant patients, where we saw more invasive aspergillosis. The most common sites of Candida infection were bloodstream, followed by intra-abdominal infections. And most of these infections occurred in the early post-transplant period. They were related to surgical complications. And so you can see that the median time to onset was about 80 days following transplant. This is a table from the same study, which, as you can see, candidiasis was the most common infection in all of these solid organ transplant patients, with the exception of lung transplant, where you can see that 44% was caused by aspergillosis and only 23% of invasive fungal infection was caused by candidiasis. This is a 60-year-old gentleman with acute myeloid leukemia who presented with febrile neutropenia and a rash. He was subsequently found to have disseminated Candida lusitania infection. And so, Candida species are normal human commensals. We know that they live in our gastrointestinal system, our respiratory system, they line our airways, and they also live in the female genital system. And so invasive candidiasis is actually a disease of modern medicine. Risk factors for invasive candidiasis include broad-spectrum antibacterial use, indwelling intravenous catheters, total parenteral nutrition, cancer treatment, immunosuppression, and organ transplantation. And in the last decade, because we've used a lot of fluconazole prophylaxis, we are starting to see an increased incidence of both fluconazole-resistant Candida species as well as non-albicans Candida species causing invasive disease. And so This shows the different Candida species that can cause invasive candidiasis, and I'd like to direct your attention to this particular species in the last row. This is Candida auris. Now, in 2016, the United States Centers for Disease Control and England's Public Health issued this warning about this emergence of a new multi-drug resistant Candida species called Candida auris, which was resistant to pretty much all or most available antifungal agents, as you can see here, and it was associated with nosocomial or healthcare infections and caused high mortality. So this was thought to be a global health threat in 2016, and it has spread to 30 countries up until now. Moving on from candidiasis to the next organism on our list. This is a clinical vignette, and this is a patient that I saw at the University of Colorado a few months ago. 72-year-old male with relapsed diffuse large B-cell lymphoma, status post chemo, and he also had an autologous stem cell transplantation in August 2018, after which he received CAR T-cell therapy. CAR T-cell, this stands for chimeric antigen receptor T-cells. These are genetically engineered T-cells which attack cancer cells. So he got that in April 2019, and in Jan 2020, he presented with fever and hypoxia. And as you can see in the chest CT, there is diffuse bilateral ground glass interstitial opacities. And on lab work, we found that serum beta-D-glucan was significantly elevated. He underwent bronchoscopy with lavage, and the diagnosis was established by a test done on the bronchoalveolar lavage sample. And this is the result here. You can see the organism. This is direct fluorescent antibody test, and these organisms are, you can see these nice rounded structures with intracystic bodies. This is Pneumocystis jirovecii. So Pneumocystis was originally thought to be a protozoa. It's classified under fungus based on its DNA analysis. It's unique among fungi because it lacks ergosterol, which is an essential component of most fungal cell membranes. And because it lacks ergosterol, it is insensitive to typical antifungal agents that are used to treat fungi, such as azoles or polyenes. Primary infection is thought to occur early in life, during infancy by inhalation of the cyst form. In transplant patients, we don't know if this is due to primary infection or reactivation of prior infection. The question of human-to-human transmission is also not well understood, but we have had case reports of clusters of infection that have been described among transplant patients in the same unit, meaning was there human-to-human transmission occurring between these patients. Nowadays, all transplant patients are placed on PCP prophylaxis with Bactrim for a few months after transplant. Before routine prophylaxis was used, the incidence among transplant patients was 5 to 15%. The major risk factors for pneumocystis pneumonia are lymphopenia, concurrent cytomegalovirus infection, hypogammaglobulinemia, allograft rejection therapy treated with lymphocyte depleting agents such as antithymocyte globulin, and corticosteroid use. Clinical features include fever, dyspnea with hypoxemia, cough which predominantly is dry, diffuse interstitial processes, elevated serum lactate dehydrogenase, and elevated serum beta-D-glucan. Now, I just want to take a minute to explain what beta-D-glucan is. Now, this is part of fungal cell wall, and it helps with cross-linking and provides strength to the fungal cell wall. And it is thought that serum beta-D-glucan, beta-D-glucan is excreted or secreted into the patient's blood when there's fungal infection. And please note that there's two main fungal groups that do not produce beta-D-glucan, and therefore it can be falsely negative when people have these fungal infections. One is mucormycetes, and the second one is Cryptococcus. If somebody has invasive Cryptococcus infection or mucormycosis, their serum beta-D-glucan is going to be negative. And treatment for PCP or pneumocystis jirovecii is Bactrim and steroids in severe cases. Moving on to the next patient, and this is a patient that's actually currently hospitalized at our university as we speak. 72-year-old gentleman with end-stage renal disease secondary to diabetes hypertension underwent deceased donor kidney transplant in June 2020. Now, about 4 to 5 weeks after transplant, he presents with headaches, photophobia, slurred speech, and fatigue. He's on triple immunosuppression with tacrolimus, mycophenolate, and prednisone. He also received a dose of belatacept, which is a T-cell co-stimulatory blocking agent. MRI brain was negative. CT chest showed lung nodules. Here's the interesting part. Blood, urine, and CSF cultures all grew this yeast. What is your diagnosis? So what I'm going to show you here is a hematoxylin and eosin stain, which shows multiple yeast. They are all round, different sizes, and you can see narrow-based budding happening. And over here, this is a mucicarmin stain, which stains any mucopolysaccharide capsule dark pink to red. And you can see that this yeast has this thick capsule around it. This is how the colonies of this yeast grows on Sabouraud's dextrose agar medium, which is a routine fungal medium. They are smooth and creamy, and it is urease positive. So the diagnosis is Cryptococcus. This is the third commonest invasive fungal infection among solid organ transplant patients. It has been historically associated with avian droppings, especially pigeon excreta, but it's also found in decaying plant and soil matter and trees. There are two main species, Cryptococcus neoformans and Cryptococcus gattii. Cryptococcus neoformans has a worldwide distribution. Cryptococcus gattii is more confined to certain geographical regions. In the United States, we find this happening in the Pacific Northwest, including, Seattle and Portland, Oregon regions. Clinical syndromes. Cryptococcus can cause just isolated cutaneous, can cause pulmonary, neurological, Cryptococcus meningitis, and disseminated. Our patient unfortunately has disseminated disease, which has a poor prognosis. Liver transplant recipients, for unclear reasons, have a higher risk of developing cryptococcosis and disseminated disease. Usually, this is a late occurring infection with a median time to onset about 16 to 21 months after transplant. If infection occurs in the early post-transplant period, you need to consider donor-derived infection, meaning did our patient get cryptococcus from the donor? And that's something that we are investigating as we speak. The major complication of CNS disease is, elevated intracranial pressure, hydrocephalus. So you need to do serial lumbar puncture or place a drain for management of intracranial pressure. We treat patients with disseminated cryptococcosis with a combination of liposomal amphotericin plus 5-flucytosine. And once infection is deemed controlled, we can switch to maintenance therapy with fluconazole high dose for at least 6 to 12 months. And of course, we need reduction in immunosuppressive agents as well. So we've actually stopped most of the rejection medications in this patient. Cryptococcus on histopath, it causes mixed suppurative and granulomatous reaction. Again, the yeasts are really round and they vary in size, and they bud, they produce narrow-based budding. And the capsule, this is really one of the classical things that we look for in Cryptococcus. They have these thick mucopolysaccharide capsules, and that's stained by mucicarmin stain, as you can see here. And this is the classic India ink stain, in which you can see the capsule very clearly. Now, Cryptococcus species also have melanin in their cell wall, and so this is picked up by Fontana meson stain, which stains the melanin, and the colonies will grow as brown colonies on bird seed agar, And lastly, okay, so I want you to see that on routine fungal medium, the colonies of Cryptococcus and Candida look pretty much identical, but there's an easy way to know or differentiate between the two. Candida is going to be urea negative or urease negative, whereas Cryptococcus will be urease positive. Moving on from yeast to dimorphic fungi. Now, these are fungal organisms that have the unique ability to grow as mold in the environment or when cultured at lower temperatures, but they will have a yeast form inside the human body or when cultured at higher temperatures of 37 degrees Celsius. So think of them as if they are somebody with multiple personality disorder, meaning they change the way they look depending on where they are. So when I teach my fellows this, I tell them that there's an easy way to remember this. Mold in the cold, meaning they'll have the filamentous hyphal forms in the cold, and yeast in the beast, beast meaning us. So inside the human body, they take on the yeast form. Now, all of these dimorphic fungi, with the exception of Sporothrix, share predilection to cause primary pulmonary infection and can disseminate in the immunocompromised patient. And all of them get treated with amphotericin-based therapy, and then we de-escalate to one of the triazoles. Itraconazole is most commonly used for this indication. This is the map of continental United States, and just to give you an idea as to how bad dimorphic fungi are in this country, I'm going to show you examples of 3 fungal organisms that are endemic to specific parts of the United States. So this over here, the desert Southwest, this is California, Nevada, Arizona, New Mexico, and this is where we live, or I live in Denver, Colorado. And this orange shaded area is endemic for coccidioidomycosis. You know, this is valley fever, and this purple shaded area is endemic for histoplasmosis, and this blue area is endemic for blastomycosis. So we living in Colorado, we see a lot of coccidioides and histoplasmosis. I am going to talk about dimorphic fungi that have some relevance to India, okay, or that have worldwide distribution or have their presence in Southeast Asia. Therefore, I'm not going to talk about cocci or blasto. Again, to give an example how a dimorphic fungus will look in different areas. In the body, blastomyces forms these nice big yeast forms. And outside in the culture, it's going to do this hyphal form with lollipop-shaped conidia. Same with cocci. You have these big spherules and the spores in the body. And outside in the soil or when you culture at low temperatures, you can have these nice hyphae with barrel-shaped conidia called arthrochonidia, which are highly infectious. And in the body, they're tiny leaves and they're unicellular. And outside the body, they form these hyphal structures with large tuberculate macroconidia, which to me looks like sunflower. Clinical vignette. A man in his 50s, status post-deceased donor kidney transplant 2 years ago, presents with shortness of breath, fatigue. He is originally from Western Africa and he moved to the United States over a decade ago. So kidney transplantation comes with these fatigue and non-specific symptoms. He's from Africa. He's on triple immunosuppression. And on his chest X-ray, you see this 3-centimeter mass near the left hilum. You can see the same mass on a CT chest with surrounding cavitary nodules. And this is what you see when they do a biopsy of this mass. There are yeast forms, and when you culture it, you see these nice tuberculate macroconidia. So what is your diagnosis? This is, yes, histoplasmosis, pulmonary histoplasmosis, and this is caused by variant Dubosii because he's from Africa. This is African histoplasmosis. Histoplasma capsulatum has a worldwide distribution. And it's present in soil enriched with excreta from chickens, starlings, and birds, especially bats. And so if somebody has, if they clean the chicken coop, they can get exposed to histoplasma. And these are people whose hobby is exploring caves, and this is called spelunking. And so they are at higher risk for encountering bat excreta, which often contain spores of histoplasma. Histoplasmosis is an intracellular infection of the reticuloendothelial system, and it's caused by inhalation of the fungal spores. Post-transplant histoplasmosis is quite rare. The incidence is less than 1%, even in endemic regions. However, in our transplant patients, we often see progressive disseminated infection in over 80% of patients. And again, these patients were present with fever, failure to thrive, pancytopenias, hepatosplenomegaly, pulmonary lesions, and so on and so forth. I just want to mention about African histoplasmosis, which is a separate entity than the regular histoplasmosis caused by Histoplasma capsulatum. So African histoplasmosis is caused by variant Duboisii, and it usually causes skin and bone lesions more than the regular, reticuloendothelial system. And the variant Duboisii, in the body, the yeast form is so much bigger. It resembles blastomyces, actually. So this is typical Histoplasma capsulatum, which shows these tiny oval yeast forms. And this is Histoplasma capsulatum variant Duboisii, where you see these larger, much larger yeast forms, which look like blastomyces. And as you can see here, these are the tuberculate macroconidia when you grow them at cultures in lower temperature. So this is an example of a dimorphic fungi. If you grow this fungus at our body temperature at 37 degrees, it's going to form yeast. It's going to look like this. And if you grow them at a lower temperatures at 25 degrees Celsius, it's going to form this fuzzy growth, which is mold, which is going to look like this. So they are thermally dimorphic. Moving on to another dimorphic pathogen. This is a 51-year-old gentleman from China. That's a clue. Whose status post kidney transplant 10 months back. Now he comes with worsening kidney function, creatinines going from 1 to 5.3, and they did a biopsy which showed granulomas and multinucleated giant cells, and they also saw fungal organisms. And this is what they see. Intracellular oval tiny yeast. Again, this looks like histoplasma to me. However, on high power magnification, what you see here is these septations. They divide by binary fission and they don't divide by budding. So that's a big clue. The second thing is when you culture this pathogen, there is a diffusible bright red pigment that you can see in the culture plate surrounding the fungal colony. And when you touch prep this and do a lactophenol cotton blue strain, you're going to see these nice conidia, the hyphal form, to me, which looks like a paintbrush. So this is very different from histoplasma. What is your diagnosis? So the diagnosis is Talaromyces mononephri infection. And when I was in med school, we used to call the same pathogen Penicillium mononephri. So we used to say penicilliosis, Penicillium mononephri, but because of some DNA analysis, the pathogens classified under the genus Talaromyces. And so this is the endemic region, Southeast Asia, as you can see here. And we're seeing a big outbreak of this infection that correlated with an outbreak of HIV/AIDS, especially in Thailand, Hong Kong region. Bamboo rats serve as reservoir for this pathogen. And this is a picture of somebody with HIV/AIDS with these, disseminated skin lesions with complication. They kind of resemble lesions of molluscum contagiosum, which is a pox virus infection. but this is actually disseminated infection by Taloromyces mornifii. Moving on, this is another dimorphic pathogen. Okay, so 50-year-old female who's a liver transplant recipient. She presents with skin lesions on her left upper extremity. This is 2 years after transplant, and she had recently traveled to Brazil. She petted local stray cats there. She owns a garden nursery, has been in contact with a lot of plant matter, including moss, hay, thorny flowering bushes. It's, rose bushes, and she lives on a farm. Let's see what's going on here. So she had a biopsy of these lesions. And before we go further, I just want to describe what these lesions look like. You can see that they are kind of nodulopapular, sometimes ulcerative lesions. And the major finding here is that, they are spreading in a presumed pathway of lymphatic channels. So this is called lymphocutaneous spread. Whenever you see this, I want you to keep, in addition to this fungal pathogen that we'll talk about, you should also keep nocardia, leishmaniasis, non-tuberculous mycobacterial infection, especially Mycobacterium marinum infection in mind, okay? Moving on, somebody did a biopsy and they saw these yeast forms, and they're described as cigar-shaped yeast. And they also find this structure called asteroid body occasionally. Culture, kind of dark. And on touch prep of this mold, you see this nice hyphal structure with what is your diagnosis? Yes, so this is sporotrichosis, another dimorphic fungal pathogen. Sporotrix schenki is a species complex of 5 different species. So Sporotrix schenki sensu stricto and Sporotrix brasiliensis are the major pathogens involved. And this is a world map, and you can see that these are the countries where we have issues with sporotrichosis, and India is also part of those countries. So Sporotrix brasiliensis is endemic only to Brazil, and this has been a causative pathogen for one of the largest zoonotic infections in the world. So from 1998 to 2016, over a little under 5,000 cases have been spread by stray cats in Brazil to humans. And in the United States, we more commonly see infection caused by the first species, Sportrix schenki, and this is more related to contact with hay, sphagnum moss, and it's also called a rose gardener's disease because, people get pricked by the thorn, which injects the fungal spores inside the skin and soft tissue. So sporotrichosis is the only exception to dimorphic fungal pathogens that most likely people are not inhaling the fungal spores. They get infection by, cutaneous contact. Therefore, clinical presentation, commonest is cutaneous, like what I saw in the patient. Also, next common is osteoarticular, but rarely pulmonary infections and disseminated infections have also been described. We treat sporotrichosis with amphotericin and itraconazole, just like many of the other dimorphic pathogens. Moving on from dimorphs to filamentous fungi or molds. Again, in the United States, the kidney transplant recipients have the highest number of these infections just because we do a lot of kidney transplants in the country. However, lung transplant and liver transplant recipients are at highest risk for mold infections. So are hematopoietic stem cell transplant recipients. Usually, you can see here that the median onset of infection after transplant tends to be anywhere from 10 months to 15 months post-transplant. So majority occur within the first year after transplant, and majority of infections occur by inhalation of fungal spores, but they can also occur from direct cutaneous contact. Now, in order for a mold to become a significant pathogen in the human body, they need to be thermotolerant, meaning they need to be able to survive and grow well at higher body temperatures. And so these pathogens can invade internal organs and survive there. Size of fungal spores also matters. Aspergillus conidia are really tiny, and so when somebody inhales them, they directly go and deposit in the alveoli. In contrast, the spores or conidia of mucormycetes tend to be larger and may get trapped in the upper airways and sinuses, hence their predilection to cause upper airway invasive sinusitis, orbital, rhino-orbital disease. Prior exposure to antifungals, many of our transplant patients are placed on antifungal prophylaxis for many months to years. If somebody is on voriconazole prophylaxis, remember that voriconazole has no activity against agents of mucormycosis, and so these people can have breakthrough infections with mucormycosis. If somebody is getting inhaled amphotericin, we see this quite often with our lung transplant patients, they are at increased risk for pathogens which are inherently resistant to amphotericin, such as Scedosporium and Lomentospora. Clinical vignette. So there are two cases here. Both are cutaneous fungal infections. First one is a 51-year-old woman with acute myeloid leukemia, profound neutropenia with WBC of 0.2. She presents with neutropenic fevers and she has these necrotic skin lesions. We take a biopsy and we see the structure here, okay? I'll come to this in a minute. Second one is a 50-year-old lung transplant patient. Many years ago, she bumped her leg against the oxygen tank and then developed what appears to be cellulitis, but she failed routine antibacterial, antibiotics for cellulitis, and biopsy shows this thing, this fungal organism. So what you see here are septate hyphae that divide at acute angle or 45-degree branching. And again, you can see these nice septations. And they have a uniform diameter. It looks like a railroad track because they are parallel to each other, the fungal walls. And when you culture them, it's a fuzzy mold, and there is a nice bright green pigmented colony in the middle with white rim. And on lactophenol cotton blue staining of this colony here, you can see this nice structure. So this is a vesicle, as you can see here. And these bowling pin-like structures are phyllets, as you can see here. And on top of that are the spores or the conidia. And so this is Aspergillus fumigatus. This is one of the most common mold infections that occur in transplant patients. Other related Aspergillus species include, like this one has a black colony on top, and this shows that the full vesicle is completely covered with phyllets and conidia, and they look brownish black. And this is Aspergillus niger. And this has yellow colony. This is Aspergillus flavus. And this one has a tan to cinnamon sugar brown colony, and the structure looks very similar to a fan brush. And this is Aspergillus terreus. Aspergillus terreus is the only species of Aspergillus that has inherent resistance to amphotericin, and is the only species to produce conidia in vivo inside the human body. Aspergillosis. Now, this is a highland mold that is ubiquitous in the environment. It's present everywhere. Exposure is common, but invasive disease is highly uncommon. So I can guarantee that all of us who are listening to this lecture have inhaled the spores of Aspergillus because, like I said, it's everywhere and it has a worldwide distribution. However, Our immune system, which is highly complex and has evolved over millions of years, is very good at attacking any pathogen that it perceives as a threat and keeping things under control. However, in patients with compromised immune systems, especially those who are on corticosteroids or who are profoundly neutropenic, these conidia, once they get into the human body, they germinate and become hyphal structures, and without our immune system, they will go on to cause invasive aspergillosis. Like I said before, this is the most common invasive mold infection in transplant patients, and 75% of infections are limited to the lungs because that's the mode of acquisition of the infection. Aspergillus fumigatus causes about 73% of infections. It's the most common species involved. Risk factors, remember neutropenia. Profound neutropenia, I would say, is a single important risk factor for development of invasive mold infections. But also remember glucocorticoid use, hematopoietic stem cell transplant patients, solid organ transplant patients, particularly lung transplant patients, and patients who take biological agents such as tumor necrosis factor alpha inhibitor for autoimmune disease are all at risk for developing invasive mold infections. Pulmonary infection, is the most common, but of course you can have disseminated central nervous system, isolated cutaneous infections as well. This is a lung which is completely infarcted due to invasive severe pulmonary aspergillosis. This is a brain imaging where you can see aspergillosis causing brain abscesses. This is a patient with this necrotic skin lesion and was found to have isolated primary cutaneous aspergillus infection. For diagnosis, we use this test called we use this fungal marker called Aspergillus galactomannan. Now, galactomannan is a compound that is present in the cell wall of Aspergillus species mainly, and it is thought to be detected in the patient's bloodstream or the respiratory secretions, even in early cases of invasive aspergillosis. So we use this indirect fungal marker in many of our patients. And the bronchoalveolar lavage galactomannan is the preferred test for pulmonary aspergillosis, along with, of course, CT imaging and culture data. Beta-D-glucan is also used, but it has a sensitivity only about 50 to 70%. Some centers, especially in Europe, use pan-aspergillus PCR assay, which has a much higher sensitivity and specificity, and they can do it on respiratory sample and blood sample. Please note that aspergillus galactomannan can sometimes be seen in other fungal infections, especially due to Fusarium, Thalassemiosis, and histoplasmosis. We treat aspergillosis with voriconazole or isavuconazole. This is a newer triazole agent, which is much better tolerated than voriconazole. But of course, we can also sometimes use liposomal amphotericin. Combination therapy is usually not recommended, but in very severe disseminated cases, or if you suspect a possible, azole-resistant aspergillus species, sometimes we've done combination with voriconazole plus an echinocandin, such as anadulafungin. Moving on from aspergillus to the next pathogen. Now, this is a very, very important aggressive mold. This is something that we call a true medical emergency from a transplant infectious disease perspective. 60-year-old male heart and kidney transplant patient 5 years ago presents with fever and dyspnea, and we found this large mass-like opacity on his chest X-ray, and this is the CT chest which shows the same consolidation in the right upper lobe, and it was thought to be a necrotic pneumonia. On day 2, percutaneous needle aspiration of the mass was performed, and they found this structure. So this is a mold or a filamentous fungus. You don't see many septations here. And it looks like a ribbon, it's very friable, it's folding onto itself. And it's actually dividing at a 90-degree angle instead of a 45-degree angle. So because we know how aggressive this mold can be, on hospital day 4, the right lung upper lobectomy was performed, and a calcifor white stain, which is a fluorescent stain which detects fungal, pathogens, shows this extensive fungal hyphal forms here. And on histopath, H&E shows the structure here. This is a mold, again, aseptate, posiseptate, and the diameter is not uniform. It's just very irregular. It's very friable. It'll fold onto itself. And the same you can see with the Gomori methanamine silver stain. This is a lactophenol cotton blue of the culture growth, which shows these structures. These are root-like structures, which are called rhizoids, and these are sporangiospores with spores inside them. This is pulmonary zytomycosis caused by Rhizopus species. Fortunately, this patient did quite well. He got aggressive surgical and got treated with antifungal therapy with amphotericin, followed by posaconazole. This is another patient of mine, 78 with myelodysplastic syndrome, neutropenia with absolute neutrophil count of 500, came with neutropenic fevers, and he was found to have the skin lesion on his hand, but with no other lesions in his brain, sinus, or lungs. And again, biopsy shows a similar mold form. This was primary cutaneous mucormycosis, and cultures grew Rhizopus species. And he also is doing much better after, liposomal amphotericin, and then he got isobuconazole, and he's doing much better. This is how the lesion looks like now. And again, another patient with, after heart transplant, he was found to have gastrointestinal mucormycosis. On upper endoscopy, you can see these necrotic lesions in his stomach and duodenum. He underwent a gastrectomy, and you can see gastric necrosis. And he eventually died because the infection had spread to his pancreas, spleen, and it was disseminated, and he died. So mucormycosis, these are highly aggressive, angioinvasive group of molds, very potentially devastating infections. Mortality rate is over 50%. Okay, so 1 in 2 people who end up with mucormycosis will die. Spores are ubiquitous, meaning they are everywhere. So again, just like Aspergillus spores, we are all inhaling spores of these molds, but our immune system is very effective at containing and preventing invasive infection. Now, these fungal spores are especially seen in tropical soils, poorly maintained heating ducts, and soils of indoor potted plants. That's why we tell our transplant patients not to keep any indoor potted plants after transplant, and to wear a mask if they are working in the garden or in the yard. Incidence in solid organ transplant patients is less than 1%. Remember that they have a tendency to break through, and cause infections while patients are taking antifungal prophylaxis against aspergillosis. So if somebody's taking voriconazole, which prevents aspergillus but has no activity against mucormycosis, this can break through. There are many species, but Rhizopus causes 75% of infection. Hallmark pathogenesis is angioinvasion. This causes hemorrhagic necrosis, vascular thrombosis, and infarction. Risk factors include diabetes mellitus that is poorly controlled, corticosteroids, neutropenia, prior voriconazole or caspofungin use, which causes selective pressure, or break in skin integrity, which can cause primary cutaneous mucormycosis. Clinical syndromes, can cause pulmonary disease, rhino-orbital-cerebral disease, again, specifically or especially seen in our uncontrolled diabetic patients. It can cause disseminated disease. We see this quite often with liver and heart transplant recipients. Primary cutaneous disease, as we saw in our patient, which has a slightly better prognosis. And gastrointestinal disease. It's rare, but prognosis is pretty poor. And lastly, we've seen bronchial anastomosis infections in our lung transplant patients. Now, management, we need antifungal therapy to be started as soon as possible, and also surgical excision and debridement is recommended for all infections outside of lungs. So usually we start off with liposomal amphotericin, and sometimes we add an echinocandin or an azole active, mold active azole as combination therapy. And once the infection is controlled after a few weeks or months, we can step down to maintenance therapy with posaconazole or isavuconazole. Again, just so you never forget how mucormycosis looks like: broad, ribbon-like, non-septate or pauciseptate hyphae with right angle branching, and they grow pretty fast, okay? They'll grow in 24 to 48 hours. Now remember, because they're so friable, many labs, they grind the tissue and then they put it in fungal culture medium. And so cultures are frequently negative if they do that. Again, rhizoids, remember, when you see the structure, this is going to be, mucormycosis. And then you have this nice sporangium with sporangiospores inside. And this structure is called an apophysis. Depending on the shape of the sporangium and apophysis, you can know what species it is. For example, Rhizopus, remember, has this nice globosporangium, but it also has these rhizoids or root-like structures at the node. That's why it's called Rhizopus. Mucor does not have any rhizoids. Lectimia has this nice pear-shaped sporangium. And you can see Cunninghamella looks like a flower, and Saxenia looks like a chemistry beaker tube to me. It'll grow very, very fast and lift the lid overnight. So if you don't tape the fungal culture, the spores are going to contaminate your entire fungal lab. So very aggressive moles. What are the radiological signs of pulmonary angioinvasive mold infections? They can cause, this is a halo sign, which is a sign of hemorrhage around the nodule. So there is thick consolidation followed by ground glass surrounding it. And this is a halo sign. Now, air crescent sign happens as a sign of recovery when the central necrotic lung separates from the surrounding parenchyma and there's a crescent of air. Usually, this is a sign of recovery. And then you have a reverse halo sign where there is central ground glass opacity surrounded by consolidation. And these are multiple nodules that can sometimes be seen. And this is a patient with and then it became a reverse halo sign. And this is a patient with aspergillosis, which started as a halo sign, and now you see air crescent sign after neutrophil recovery. And so, the main thing is with mucorales, you see a larger ground glass halo because of how aggressive they are with inflammation. You see the reverse halo sign much more common than the halo sign. This is another mold that is equally important. A teenage girl with acute lymphoblastic leukemia received chemo, profoundly neutropenic, comes with neutropenic fevers and these skin bumps. And you can see it has psychosis, some nodules in the lungs. Ophthalmic exam showed concerns for fungal endophthalmitis, and nasal exam showed this necrotic, concern for invasive fungal sinusitis. And biopsy of the skin lesion shows the hyphal structures that are very similar to aspergillus. However, on culture, you see these nice lilac-colored mold colonies, which on lactofilm blue, you see these This is a very important clue. And the fungal onychosis. Which is very aggressive infection. I do want to say that blood cultures also grew a mold in this case. Aspergillus and mucor, usually blood cultures are not positive, but there's some mold that will be positive, that'll grow well in regular blood cultures. Fusariosis, it is a soil saprophyte and plant pathogen. So again, don't have your transplant patients grow indoor potted plants. And the hyphae looks very similar on histopath to Aspergillus and other filamentous fungus. And there's two main species, Fusarium solanii and Fusarium oxysporum. In a normal host, it can cause keratitis, especially in contact lens users. It can cause, fungal nail infection. But remember, it can cause disseminated infection in immunocompromised patient, and blood cultures are positive in about 40% of these patients. And usually they can be resistant to amphotericin, but we start with voriconazole, amphotericin, and we do susceptibilities. I'm going to skip this in the interest of time, and we'll just let you know that there's another group of fungus called Demariaceous fungi, which have there's about 100 species, and they all produce melanin pigment, and therefore any disease that's caused by them is called pheohyphomycosis. And this is a colony of a demariaceous fungi, which is black both in the front and the back. And to contrast this, the colony of Aspergillus niger, even though it looks black on the top, if you reverse it, it's yellow. So Aspergillus is not a demariaceous fungi, okay? And this is an example of a demariaceous fungi causing lung and brain abscesses. This is caused by Phylophora in a kidney transplant patient. And again, mortality rate can be very high, even up to 75%. And this Cladophylophora has propensity for neurotropism and cause CNS infections. Okay. Lastly, I just want to touch on briefly on antifungal agents. And what I'd say is, in our clinical practice, we use triazoles, which have, fluconazole, itraconazole, voriconazole, posaconazole, isobuconazole, echinocandins, which have these three agents, anidulafungin, micafungin, caspofungin, and polyenes. That's amphotericin-based therapy the most. Now, these two are fungistatic, but amphotericin is fungicidal. And both triazoles and polyenes act at the cell membrane. It has got something to do with ergosterol, whereas echinocandins inhibit beta-D-glucan synthesis, which is a component of cell wall, not cell membrane. This is the last slide. I know it's busy, but I'm going to just try and walk through some important points about these fungal agents. And, basically we'll look at if they cover Candida species, Cryptococcus, dimorphic fungi, and molds. Fluconazole, we mainly use it for Candida infections, but we also use it for Cryptococcus and Coccidioides. It has no mold activity, as you can see here. The loopholes are Candida krusei tends to be fluconazole resistant, and Candida auris, I already told you, it's a multi-drug resistant newer species of Candida. And again, no mold activity. Itraconazole has an extended spectrum coverage, meaning it has some mold activity, but it has issues with hypertension and exacerbation of heart failure, and it also has issues with oral bioavailability and absorption. So we mainly use it just for treatment of dimorphic fungi, including blastomyces and histoplasma. Voriconazole is our first broad spectrum mold active azole. It is available in intravenous and oral forms. It is not very well tolerated because it can cause skin cancers, visual disturbances, and periosteitis. The main problem with voriconazole, even though it has good Aspergillus fusarium coverage, it has no coverage against mucormycetes. So breakthrough infections can happen if somebody is just on voriconazole. Posaconazole and isobuconazole, these are excellent broad spectrum triazoles which have coverage, as you can see, all the way to the molds, including mucormycetes. They come in both intravenous and oral formulations, and we use these quite often in the transplant infectious disease world. Echinocandins, they don't have any activity against Cryptococcus and minimal activity against dimorphic fungi. Even though they can be used as salvage therapy, combination therapy for Aspergillus, they have no activity against any of the other molds, including mucormycetes. Now, Candida parapsilosis tends to have a higher minimum inhibitory concentration to echinocandins, and therefore, treatment failures has occurred if you use echinocandin for Candida parapsilosis. Mostly in our clinical practice, we use it for invasive candidiasis until we know susceptibilities to fluconazole, and if it's fluconazole susceptible, we step down from an echinocandin to an azole. These come only in intravenous formulation. And lastly, amphotericin. This is our big shot gun that we have to fight fungal infections. It only comes in intravenous formulation. The major problem here is nephrotoxicity and electrolyte imbalance. Now, I just want to point out some loopholes even with amphotericin. Candida lusitaniae is inherently resistant to amphotericin, but I don't see a reason why somebody would be using amphotericin for candidiasis. Usually we go with an echinocandin or azoles. And Aspergillus tertius is also inherently resistant to amphotericin, and Scedosporium and Lometospora are also resistant. So if somebody's on amphotericin, these are the fungal pathogens that can break through even on amphotericin. And with that, I'm going to end my talk. Thank you for your attention. This is a photo that I took with my Samsung phone while we were on a recent social distancing vacation to Glacier National Park in Montana. And stay safe, folks.